Good evening and welcome to the Cancer Education Series brought to you by MercyOne and Above and Beyond Cancer. My name is Chris Goodale and I'm the Executive Director of Above and Beyond Cancer, and it is my weekly privilege to introduce the founder of our organization, Dr. Richard Deming, who will introduce our speakers for this evening. Dr. Deming?
Thanks, Chris, and thanks everyone for joining us. You're in for a treat tonight. We have a great couple that is going to be presenting to us. And I'm going to introduce you to Erin Sullivan Wagner and Dr. Amy Pearlman. Erin and I go way back to hometown, and we went to the same high school in Madison, South Dakota. Then Erin had a more illustrious career than I did. She went to the University of Iowa. And she also has her own cancer journey that she'll share with you. And she is really a patient advocate, educator, and a coach. And she has started a not-for-profit called All of Me and really focuses on sexual health, especially as it relates to cancer survivors. And we have with Erin tonight, Dr. Amy Pearlman. Amy grew up in the Washington, D.C. area, Rockville, Maryland, and then she went to Miami for undergrad, went to Baylor in Houston for medical school, did her urology residency in Pennsylvania, and then a fellowship in urologic reconstruction at Wake Forest in North Carolina. She currently heads the men's health program in the urology department at the University of Iowa. And we're really happy to have both of them here. And the topic tonight is genital rehabilitation. What can patients do after cancer treatment to minimize sexual side effects? And I'm going to turn it over now to Erin and Dr. Pearlman.
All right, well, thanks. I'm going to start, guys. Hopefully everybody can see my screen, and I feel like there is so much to say on this topic tonight, and especially where I come from, because I'm not only speaking as a patient, but an advocate for patients, and also some of the work that we're doing with the All of Me project, which is really calling out to the healthcare providers and care teams about what they can do with their patients to help them through this conversation. So there's a whole lot to say, and I'm going to go fast, but I want you to know that the information will also be made available to you on our project site, but also these slides are available for you as well too. So just to give you a little bit of background on me, I had anal cancer in 2008, and from that then I became life coach and patient advocate for just the emotional kind of side effects you have from after cancer, and realized then that sexual health was really an issue that wasn't talked about amongst most people in the medical community with patients, is what I was finding from my life coaching that I was doing. And the reason it was important to me was because sexual health issues were very common for me, was a challenge for me actually throughout my lifetime. So it was something I got very involved in and founded After Cancer Solutions for Sexual Health. And it's really just a coaching business I work with patients on. And from that really led to, I can work with patients, or I can work with providers who work with patients. And I became the voice of a patient to the healthcare community, both to the oncology community and also primary care, urologists, gynecologists, on how they can make this conversation easier for the patients that they work with. So I got involved with the Iowa Cancer Consortium and started this project where a lot of this information has been built into this project, and it's called All of Me, and it's a grant-funded project through the Iowa Cancer Consortium. It's been going on since 2016, and this is all around prioritizing and addressing sexual health in cancer patients after their treatment. Well, actually during too. So just a little bit about all. Yeah.
Erin, go to slideshow view. Yep, and go to presentation from beginning or from current slide. Yep.
Here?
No, one more over to the left. No. Get rid of that. From current slide.
Okay.
Yes.
Better?
Yeah, great, thanks.
I wonder if will it automatically then? Okay. I'll keep going and see if I can make it go to the next one just by hitting my down. Okay, so around this project, so there was a public awareness campaign. We targeted, we had focus groups where we talked to them about what are the barriers to care. And we started this site. It's allofmeiowa.org. Just remember that. That'll be a site that you might want to go to later. We did a lot of videos, workshops throughout the state, did a patient brochure, so that's available to you on that site. Lots of educational calls, and we're doing pilots this year, 3 of them in 3 different clinics, and it's addressing sexual health, but really implementing that framework of ours to address sexual health in cancer care. So those 3 pilots are happening now. I don't have the data from the results of those yet. And we're doing a conference in April of this year, and you'll get information about that. Even though this conference is really geared to providers, the healthcare teams, patients are definitely welcome. We'd love to have you join, and I think a lot of the information you'll find is good. This project is really around this implementation framework of normalizing the conversation for patients. So what we help, this is educational material for the provider community, and they learn a 30-second message all around normalizing this conversation for their patient, then set expectations where needed, and then refer patients out in a timely manner. Those are the 3 pillars of this. And this slide, I know it looks like a bit of just a really eye chart, but what this is it really shows you how cancer-related issues all build on each other. So cancer-related fatigue, all of these, I guess I should say that many cancer-related factors can contribute to the web of sexual dysfunction after cancer treatment. And for example, if you start out with painful sex, from any one of the number of reasons there, that can contribute to an unsatisfactory encounter for sure. This slide lists, even though this is true for people that don't have cancer, this slide lists specifically cancer-related causes that add to the complexity of the problem with sexual function after cancer. And this is really what you end up with. So if you start with painful sex, it's hard to get anywhere but an unsatisfactory encounter. So it just shows you how this can be a web of sexual dysfunction. So a little bit about my journey. So I was 48, soon to be 49, when I was diagnosed with anal cancer. And just for your information, the way I found out was I had a little bit of blood with a bowel movement, just a little bit. I didn't have a history of hemorrhoids. It concerned me. So I got it checked, and that's how it was diagnosed with a colonoscopy. And I had radiation and chemo treatment. When they were deciding how they were going to treat this, they said that, 90% survival rate, right? I mean, everything was good. Even though this diagnosis is devastating when it's your first cancer diagnosis, the survival rate was so good. And I was told I would have no sexual health issues. So I really felt like I was going to breeze through this. I pretty much did. Chemo and radiation, 5 weeks, but got very sick at the end. Healed up though, and within 6 weeks, I was told that we could continue all activity and sexual activity for sure. However, they really couldn't have been more wrong. So we tried to have intercourse, and quickly, immediately, urgently realized how terrible that was for me. There was just no way. It was just severe shooting pain, and there would be no way you could get through it. I've tried to describe it a number of different ways, but I went back to my provider, and I was at the University of Iowa, and went back and said, I was told there'd be no sexual health issues afterwards, but intercourse is impossible. And they were like, wow, never heard of this before. I don't know what that would be. Let us check into it. So I went to the surgeon that had originally, I didn't have surgery, but that had originally diagnosed me, and asked about it. And they just hadn't spent much time figuring out what about this anal cancer was causing sexual health issues afterwards with intercourse. They didn't really necessarily look into the treatment that I was having. They just talked about, well, we haven't had a lot of anal cancer in our past, so maybe that's it. I went back a 3rd time. Eventually, I was referred out to a gynecologist. And the gynecologist, when she evaluated me, my cancer was in January. I was done with treatment by March. I was at a gynecologist in August, and into September with an evaluation, realized that scar tissue had built up in the vagina, and that I needed a minor procedure, but that I needed much more than that too. I needed estrogen creams, I needed moisturizers, suppositories, I needed dilator tools, I needed to have rehabilitation. I needed a referral. So I started doing all of those things, and into, as you can see with this slide, this is kind of my what went wrong and when slide, just because what I wish had happened to me is all of these things that happen with a patient after they are diagnosed, then normalizing the conversation. Everybody understands the consent for treatment, how there may be literature that gives that, yeah, there could be sexual health side effects after the treatment. Everybody gets that that's brought up for consent for treatment. But setting expectations, being able to refer patients out, prescribing anything that is needed at the time, so that, you know, the problem doesn't ever build up, the scar tissue doesn't build up. All of those things I would want to have providers know about, bring up, and normalize that, to talk to their patients about, in some cases set expectations and refer them out. All of that to happen in that diagnosis to 3-month time period. If you look at the line of what happened to me, so I was diagnosed in January. By the 9th month, they were referring me to the gynecologist. What ended up happening with me is I immediately started on vaginal suppositories and estrogen creams, and went to rehabilitation therapy where they would knead the muscles of the vaginal tissues so they weren't so much like concrete. I was prescribed, well, the Pearlman cream, and then lidocaine and Sullivan, and eventually Xanax. I mean, this went on for years, really, that I chased how to figure out what to do to make it work. And what ended up happening in our relationship, and that's probably really what's really most important here, is the impact that these issues have on intimate relationships. We just didn't know what to expect. So I didn't know that I wasn't chasing a problem that couldn't be fixed. I didn't know. So we chased every problem there was. And in the meantime, intercourse was impossible. And it got to the point where, I mean, I really could see the disappointment on my husband's face. And I know at first he was just very, very concerned that he was causing that kind of pain for me whenever we would try. It never lasted very long. But not only was he disappointed, though, really just human, he was very frustrated and eventually just very quiet. And I've told people before in the past that when I described kind of the gradual erosion of our relationship, it really was gradual, and it happened over a period of time. We lived together. We knew each other's schedules. We had 4 active children, and we showed up for dinner. We slept in the same bed. We just really weren't very connected. And it all came from just that not being able to have intercourse and chasing that problem and the disappointment he had about it, and the healthcare community not understanding why I was having that problem even caused him to go so far as to question whether or not it was in my head. And you can imagine the conversation, you can just imagine how that went. But anyway, so it got to the point where we gradually stopped spending that time together, stopped, you know, that alone time that leads to something else. We had to change our sexual scripts, but we didn't do it. So we ended up just slowly moving apart from each other until we separated in 2016. All of that could have happened here, and the outcome of that to 2016 could have been very different. So these are, and I want to get to this part of it because it's really why we're here, where you weren't here to listen to everything else. These are considerations. So Dr. Pearlman is going to go into this from a men's health perspective, but this is from a female health perspective. There hasn't been in the past that I can find a portal that would give women going through menopause or sexual health issues after cancer a portal to look at, what do I need to think about? What's the difference between a moisturizer and a lubricant? When do I use dilator tools? How do I use dilator tools? Where would I buy those? Who should I buy those from? We are putting together, as part of our project, this patient handout. So this is all going to be available to you guys. It'll be on the allofmeiowa.org website. And this is put together by Dr. Veronica Colder, who is retired now, lucky her, former medical director of Menopause and Sexual Health Clinic at the University of Iowa and clinics. And so she is also a consultant on this project. And these are her clinical considerations. Because this is massive. It really is great amounts. You guys really need to just mull over it. Take the time to mull over it. I'm going to go through it really fast to let you know all of what's here. So this is all the non-estrogen approach to reversing these symptoms of menopause. And it does address vaginal atrophy pretty specifically. So the effects of pelvic radiation is what you could say for that. So vaginal moisturizers, so they really thicken the vaginal tissues and make them more elastic. Those are the moisturizers, and there are different, they say to use them at different, depending on which one you use, but some will say these should be used immediately after treatment. So that you aren't allowing that scar tissue to build up, like in my case. So the vaginal lubricants, though, not moisturizers, this just gives you a choice of those. And there's a vulvar skincare guideline that will be on the website as well. And the website's also being revamped, you guys, so go easy on it. When you go there, it looks maybe like there's just a lot of information, not as organized as I'm going to have it really soon. But you'll find all of this in patient resources. The dilators. So this is another important piece that was missing on my care. And this is just a simple, smooth device that's used to stretch the vagina. And there are graduated sizes. So, you know, for me, I needed to really start with the very, very smallest, which is about the size of my little finger to insert. And then they, there's pressure put on that dilator. You can use pressure to just stretch the vaginal muscles. So pelvic floor physical therapy, this is actually a godsend. I mean, if you aren't considering physical therapy, you really ought to. The physical therapy therapists are really just a wonderful resource, and almost always people with pelvic radiation get referred to a physical therapist. This was something that I did for a long time. The issue I had was I wasn't referred soon enough, so they did a lot of work with me, but in the end called time and realized that the scar tissue for me had built up to the point that I wasn't elastic enough anymore to be able to stretch it, and surgery wasn't an option. So it ended up being that my sexual health issues lived with me forever. Yoga, this is newer, but this is something to consider for pelvic muscle pain. These are some websites that you can go to that will give you some great tips on just other sexual health solutions, pain-related issues. So there's barrier creams and ointments. So this was also something that was prescribed for me, barrier creams. And then actually, I think they have, yeah, they give you some prices on here too. So that's another great thing, our options and the prices. And then the non-hormonal prescription options. So lidocaine, the Sullivan cream, and when to use it, how to use it. I use the Sullivan cream really just to be a protector against have everything away from my skin. So I would use that on my skin to protect it. And the clitoral therapy device, I was unaware of this, but this can be used to also increase just natural lubrication and arousal. And then when you get into the hormone treatments, the estrogen, the DHEA, and what the differences are. So estrase and Vagifem, and you know, all of this information, you guys, was just such great information for me to have, because I thought Premarin was the cream you definitely wanted to have, and it was just so expensive. I think it was $300 for me for a tube of that. But actually, Premarin cream isn't necessarily what you want to have. It goes into detail about the horse estrogens that are in Premarin cream and aren't measured the same way in your blood, that the estrogen isn't the same way. And so why that there are options to that. And then it goes into, this also goes into some description of DHEA and what that means. So for folks that have had, you know, breast cancer, or actually anybody that's had cancer, you have to speak with your physician, obviously, about what's going to be best for you. What I'm hoping some of this information can be for you, though, will be information that you can read about, bring to your physician, ask about it. Maybe you are already taking one or the other of some of these products. and ask what the options would be. This gives you some pricing to go with as well, which I found very helpful, because it's really just impossible to go out on the internet and find what you're looking for in terms of what is the best. So as you can see, goes into quite a bit here in terms of the different estrogen, non-estrogen, and then systemic estrogen. Low interest in sex. So we kind of end here, even though there is more for you to have, but the low interest in sex, this can, it gives you the guidelines from the NCCN on what this could be. So fatigue, cancer-related fatigue is often one of those things that will be brought up. There's also the systemic testosterone that can be given. And really the important part of this, and I'll end here, is as a patient and a patient advocate, all of these things really, when you come right down to it, it impacts intimacy and your own emotional intimacy about yourself and your worth. Body image issues are just so prevalent after cancer. It's just so important that you give your patients, and patients also are armed with the information to help themselves with sexual health issues. So not just the functioning of it, but the emotional turmoil that it takes on a person to have relationships end. So Amy, I'm going to turn it over to you because I know you've got great information to give too, and I'll stop sharing and you can go from here, and I'll take any questions at the end. Thanks, guys. You're on mute. Maybe down on the lower left. There you go.
All right. Erin, thank you for sharing your story. Every time I hear we do one of these presentations together, there's always something new that I learn about you and your experience. And for the folks watching, I met Erin. Erin, we don't go quite as far back.
Not 100 years.
You know, but we met probably about 2 years ago. And, you know, much of what I hear you say has drastically changed my practice and the way in which I communicate with other healthcare providers with whom I work, and also my patients. So my practice and my patients' lives have changed simply based on some of the work that we've done together. And, you know, a lot of what Erin was talking about today when it comes to female sexual health, it's equivalent in male sexual health, and it's never too early to talk about these things. Now, what I will tell you is, you know, during surgical residency, so, you know, I did 4 years of medical school, 5 years of learning how to operate, an additional year of specialty training. And I go to training to learn how to operate, and that's really fun. And so whenever we are in clinic working with our bosses, when you're a surgeon, you don't really want to be in clinic. You want to be in the operating room doing the big surgeries. And that's true of people who treat, you know, cancers like Erin's, and gynecologists, and surgeons like me, urologists. And we operate in the pelvis. And if we're putting people on chemotherapy and doing radiation on that area, it would be ignorant for us to believe that those therapies wouldn't cause sexual dysfunction, because the nerves are in the pelvis. And so anything that it can affect any structure in the pelvis has the ability to worsen sexual function. And our goal with a lot of these educational initiatives is to teach people how to have that conversation with healthcare providers and with patients in ways that don't overwhelm people and in ways that don't embarrass people. And Erin verbalizes or phrases it in such a way. So she says, our goal is to make every conversation a vanilla conversation. So let's take, I was in clinic all day today, so I had these types of conversations 30 times today. And it doesn't matter who is in the room with me. So let's say I'm in the room and I have Mr. Smith in the room, and Mr. Smith was diagnosed with prostate cancer 6 months ago. And let's say he had his prostate removed 3 months ago. And next to Mr. Smith is Mrs. Smith, and she's in her 60s. And they also, let's say this is pre-COVID, and they also have their daughter in the room with them. We'll call her Sally. And he's coming in, let's say, to talk about urinary symptoms. So what we're trying to teach people is, how do I bring up sexual health to Mr. Smith, who was recently treated for cancer, with his wife and daughter in the room? And maybe it's something like this, and Erin describes this as the 30-second script. So I might say, it is common and expected to have a drop in sexual function related to prostate cancer and prostate cancer treatment. And sexual health can be medical health concerns. And it might not be important to you now. You're recovering from treatment. You have other things on your mind. But if sexual health becomes important to you in the future, I want you to feel comfortable to bring that to my attention. And that way I can treat the dysfunction, or I can refer you to someone who can. And you look around the room and you think about, is that embarrassing for anyone? Would Sally be like, oh my God, I can't believe Dr. Pearlman mentioned sexual health? I'm not saying, I'm not pulling out demos and being like, if your penis doesn't work and we can do a vacuum pump and all this stuff. No, I'm saying it is common and expected to have sexual side effects related to cancer care. Erin, is in any way, could that be embarrassing? Yeah, and I would say, if you're one who doesn't feel comfortable having that conversation, then our job is to get you comfortable if you're a healthcare provider. But the other message too is that our patients expect us as healthcare providers to bring this up. And we as healthcare providers assume that if it's important to our patients will bring it up. But what happens? Well, Mr. Smith is grateful that he's cancer-free. And so he doesn't want to complain about having erectile dysfunction because maybe I cured his cancer. So how rude would it be for him to bring up that concern? And I'm sitting in the room and I'm talking about, his cancer recovery. And I would assume that if he wanted to have sex with Mrs. Smith, he would bring it up. And so what ends up happening is nobody brings it up. And so maybe Mr. Smith comes in 5 years later and says, I've tried Viagra. Is there anything that you can do for me? And the reality is, wow, there are a lot of things that we can do for Mr. Smith. And for his overall health, it makes sense to have that conversation sooner rather than later. And we'll talk about some of those options today. I am a consultant for and receive grant funding from Boston Scientific as well as Endo Pharmaceuticals. And because of the products that both of these companies provide, I can do my job. So it's the work of thousands of people and a lot of money that goes into research and development that allows me to confidently tell my patients, there are very few men in whom I can't restore function. And that has very little to do with me, but has everything to do with those who have done the work before me. During the next 10 minutes, we'll talk about basic penile anatomy and the mechanism of an erection, because unless you understand normal structure and function, you can't understand what happens when things go wrong. We'll define erectile dysfunction, describe the most common causes of ED, and then most importantly, list the penile rehabilitation and treatment options. Erectile dysfunction, or the definition, is quite vague, and it's the persistent inability to reach and or maintain erection sufficient for sexual performance. Now, over 50% of men over the age of 40 will note a drop in erectile function, and that's just in the general population. So you add prostate cancer, testicular cancer, or lymphoma to that equation, and we're increasing the risk in diabetes and heart disease. All these things will contribute to a drop in erectile function. It's a vague definition, folks. So nobody has to prove to me that they have a problem. If you come in to see someone like me and you say, Dr. Pearlman, my erections aren't as good as they used to be. Can you help? The answer is yes. And yes, sometimes we use questionnaires, and sometimes we get lab work, and sometimes we get ultrasounds, and those might help guide my treatment and guide how well these medications are working. But you don't need to, fill out a questionnaire a certain way for me to believe you. If your function is not good enough, there are ways that we can improve your function. Erectile dysfunction, for many reasons, is expected, and nobody ever sits you down to let you know this information. So I have so many guys who come in and they're in their 60s and 70s, and they come in and they're like, my penis doesn't work like it used to. Is it like, why is this happening? And it's because nobody ever sat Billy down to say, hey, Billy, as you get older, this is what is common. It doesn't mean we can't do anything about it, but I do want to go over the things that are expected and common as men get older. So there is a progressive decline in sexual function, an increase in the period of time between sexual stimulation and erection. So whereas before, maybe 5 years ago, a woman sat on a guy's lap and he could get an erection, it might take some more stimulation or arousal for that to occur. Less rigid erections, less forceful ejaculation, decreased ejaculatory volume, increased refractory period between erections. So you might look at this list and say, gosh, Pearlman, aren't you a party pooper? And, you know, in some ways, yeah, I mean, these things suck. It is terrible to learn that these things are common as expected as people get older. But it just means that we're all in this together. You know, women experience changes in their bodies as they get older. And we talk about, you know, menopause and tissue changes, and folks, similar things happen with men. We call them different things, and they are different, but these changes happen, and we just have to know, you know, what we can do about them. And erectile dysfunction is extremely common. Up to 30 million men in the US and 150 million men worldwide experience erectile dysfunction. There are a lot of different causes, and we'll go through some of the medical and surgical causes. We split these up into sort of like mental health or psychogenic causes and physical causes. And we talk about the psychogenic causes as being performance anxiety, a strained relationship, lack of sexual arousability, depression, things like that. I do think that separating these things out is somewhat problematic. The reason being that if someone feels stressed, or let's say after a long day of work, the guy gets home and just wants to eat a nice meal and have some sex at night, he might not feel stressed, but he's tired. And so that feeling of feeling fatigue or feeling stressed out or thinking about the next day or worrying, okay, if I take a Viagra, am I going to be able to perform tonight? Should I even take it? Am I going to get lucky? Should I waste the medication, etc.? Those feelings are actual chemical reactions occurring in the body. They don't just come out of thin air. When someone feels stressed out, you are sending signals to the body that says, hey, penis, it's just not going to happen tonight. And it kind of makes sense. If you're stressed out, why would your penis need to work? And so we talk about performance anxiety, but these things are chemical reactions. And so I do think it's problematic that we've split these things apart. But we do. And so when we think about the physical causes, or, you know, like the blood vessel and nerve causes, we call them organic. And so some of these are going to be Parkinson's, Alzheimer's, stroke, spinal cord injury, hormonal issues like low testosterone, blood vessel issues like high blood pressure, high cholesterol, tobacco, diabetes, pelvic radiation, and veno-occlusive dysfunction, which can happen if there's scar tissue in the penis with aging, penile fracture, diabetes. So when we think about normal structure and function, I have my handy dandy demo product here, all right? This is a side view of the penis. So you have erectile bodies here. You have the urethra that sits right below, all right? Now, for one to get a good erection, you need good blood flow into the penis. And the penis is very similar to sponges. So take a look at these sponges. The erectile tissue in the penis is exactly like the sponge. And then you have thicker tissue that surrounds the erectile tissue, and that's called the tunica albuginea. So if you think about like a gel pen, so like a gel pen with like a 0.7 millimeter pen, think about what the tip of that gel pen looks like. That is about the size of the artery that gives blood supply to the penis. The back part of that pen is about the size of the artery that gives blood supply to the heart. And so you can imagine if someone has high blood pressure and coronary artery disease, why that person might come to see someone like me 5 to 15 years before they present with symptomatic heart disease. So that blood vessel gives blood to this spongy tissue. And if someone is stressed out, that blood vessel won't open up to accommodate more blood. So it doesn't matter how aroused you are, it just won't happen. Okay, so you get good blood flow in. Let's say that, you know, you're not stressed out, you're feeling good, you know, nice and relaxed. You get good blood flow into the penis. That increased blood flow will fill the spongy tissue in these openings. You can see right there, okay? The tissue, the penile tissue will engorge and it'll compress the veins that are draining the penis. So you need good blood flow in, you need those veins to close off to get a good erection. Now, the veno-occlusive disease, so that can be problematic after pelvic surgery or radiation. So even if you have good blood flow in the penis, if those veins aren't collapsing, you'll have issues maintaining the erection. And so we see veno-occlusive dysfunction in guys who are treated with radiation or surgery, for example, for prostate cancer. We also commonly see testosterone issues in guys who have various types of cancers, as cancer treatment can affect the hormone axis. And it is quite difficult to get a good erection if you have low testosterone. But the reality is, you know, for guys who are coming in with a history of cancer or current cancer, that's not the only problem they have. They might have prostate cancer, but they also have Parkinson's and high blood pressure. And so these things don't happen in a vacuum. And oftentimes it's multiple contributors. And then you put medications on top of that. So blood pressure medications can worsen erections, antidepressants, and you would, you know, expect if someone's going through cancer treatment, then having something like depression is quite common. And then the medications we put people on for depression have known sexual side effects, and antihistamines and acid reflux medications and narcotic pain medications. And, you know, a little bit of alcohol might improve erections, but a large amount of alcohol can worsen erections. So you have to look at the whole picture. It's the cancer diagnosis, plus the other medical problems, plus other surgeries that have happened, and then medications on top of that. Now, with any of these medications, if you or someone you know or your patient is on these things, we don't just want to stop them, but we do encourage our patients to reach out to the prescribing provider for our patients to ask them, okay, I know I'm on a beta blocker like metoprolol for my heart. Are there alternative medications you can put me on with fewer known sexual side effects? But our patients have no idea. They have no idea that their medications are contributing to their sexual dysfunction. And, you know, we're supposed to have these conversations with our patients about potential side effects, but, you know, most cardiologists are probably not going to talk about sexual side effects related to blood pressure medications. And that's why when Erin says, you know, we have to have these conversations and normalize them at every step of the process, it's all of our jobs. You don't have to be a sexual medicine specialist to have this conversation, or the prescribing provider. If we see that our patients, you know, are having sexual dysfunction and they're on these medications, then a medical assistant, a nurse, a PA, a nurse practitioner, a physician, anybody can have the conversation to say, I just wanted to make you aware that some of the medications you're taking have known sexual side effects. We don't have to change the medications. We just have to educate our patients and have them reach out to their prescribing provider. But otherwise, our patients are just not going to bring it up because they have no idea what the contributing factors are. When it comes to treatments, again, there are very few men in whom we can't restore function. And any type of treatment as an initial treatment is a valid choice. We used to think, okay, well, first I'm going to put you on Viagra, and then I'm going to, titrate up the Viagra dose. And if that doesn't work, we'll try Cialis, and then Levitra, and then Stendra, and then a vacuum pump, and then a tension band, and then penile injections. And then only after that will we consider a penile implant. And maybe that might take 10 years for that whole process to happen. But the reality is now, and the way that our national guidelines recommend, is any initial treatment is a valid choice. We typically start with the oral medications because they're non-invasive and they work for a lot of people. And there are 4 FDA-approved medications for the treatment of erectile dysfunction. I have the generic names up top and the brand names on the bottom. So we have sildenafil, tadalafil, vardenafil, and avanafil. Now, when we look at these medications, I'm typically going between Viagra and Cialis. And, Levitra or vardenafil, it acts very similarly to Viagra, but it tends to be more expensive. So for that reason, that cost reason, I rarely prescribe that medication. Avanafil is a newer kid on the block when it comes to medications. And so with new medications comes at a cost. And so for that reason, it tends to be way more expensive for my patients, and cost matters. I don't want to bankrupt my patients in the process of trying to get them an erection. So for that reason, I don't think I've ever prescribed that medication. So it's really between Viagra and Cialis. Now, Viagra is a shorter acting medication. It can work in your body for up to 4 to 6 hours. Cialis can last in your body up to 36 hours, so it's a longer acting medication. Cialis used to be cost prohibitive, but if you use a medication assistance program like GoodRx, it actually brings that cost way down, and you can get like max dose Cialis, I think 90 pills for like $50 at Hy-Vee. And so it's really taken that cost problem out of it. And so I put a lot of my patients on Cialis. Now you might say, Pearlman, whoa, hold your horse. You're saying, so what if I take a Cialis in the morning, but I gotta go to the grocery store? You're saying I'm gonna maintain an erection for 36 hours? I don't think that's gonna, fly well. No, that's not what I'm saying. It's in your system for that period of time, but you still have to be aroused to get the erection. Now, I would say with the caveat that unless you find avocados sexy, then it probably shouldn't be a problem when you're going to the grocery store, but you want to time it appropriately there. If the medications don't work, and they don't work in everybody, especially if you've had treatment for prostate cancer and you have diabetes and you have high blood pressure, all those things combined will make you less likely to respond to the pills. Also, something to keep in mind is you need good nerve function for the pills to work. So if you had prostate cancer treatment and they were unable to peel the nerves or spare the nerves on the prostate, then the medications will not work. And that's where some of these other therapies can be more helpful. This medication, MUSE, is a medication you put in the urethra. So you have the urethra here, and you would put an applicator in and put it in there, and then the tissue around the urethra will absorb that medication. Now, I rarely prescribe this medication because it tends to be more expensive than a lot of the others and doesn't work as well as some of the other therapies like the injection. So while this is an option, I don't use it very often. It can also cause some penile discomfort. What I use more often is intracavernosal injections, or injecting medication directly into the penile tissue. So this would be injecting the same medication that you could put in the urethra. It's just a different way of giving the medication. Now I'll show the needle up here, and it's really small. You can barely even see it. It's an insulin needle. So usually if I'm seeing someone in the office, I'll show them what this looks like. And even during COVID days, you can't see the bottom of the face, but you can see the eye reaction. So if someone's eyes are coming out, like this, then okay, they've told me they're not interested in injections, and that's okay. I would not enforce injections on anybody. I think some people are surprised at how well they tolerate the injections. Some people are surprised at how poorly they tolerate the injections. If there's any interest, I say, let's go for it and see how you do. The injections do not rely on good nerve function. So if your surgeon could not spare your prostate nerves, then that is okay. The injections might still work for you. We have people inject towards the base of the penis at 10 or 2 o'clock because the nerves for sensation go on top here. And we don't want to inject the urethra down here. So you hub the needle all the way and you inject the medication like so. It doesn't take quite as long to take effect compared to the pills. You do it about 10 to 15 minutes before you want to have sexual activity. Now, a vacuum erection device, this is really important for penile rehabilitation and I think very underutilized. A vacuum pump is a really good tool if you're no longer getting regular nighttime and morning erections. I have this saying, and we've heard it all before, if you don't use it, you lose it. And folks, no truer words could have ever been spoken. Just like Erin said, she should have been told to dilate as soon as undergoing cancer treatment. That is when the tissue is still pliable. So let's just think about these 2 sponges right here. If I took this sponge here and I put it underneath a sink and I wrung it out, all right, and I placed it next to the sink and I said, hey, Mr. Sponge, I'll see you back in a year. Think about what that sponge will look like after a year. It's going to be dried up and shriveled up. And if I were to put that under the sink after a year, do you think it would really expand like it did a year prior? No, I don't think so. So let's say I took a different sponge and I said, I'm going to put this sponge under the sink, and I'm going to do that every day. I'm going to put it under the sink and wring it out and put it on the side of the sink. And the next day I'm going to do the same thing and wring it out. Think about what this sponge will look like after a year. It's going to look healthier. Okay. When I put it under the sink, it's going to expand more than that other sponge. And that is exactly what it is for the penile tissue. And the vacuum pump helps stretch out that tissue to get blood flow in that tissue. And even if you can use this before sexual activity, and if you're using it before sexual activity, then you would put this like so. You would pump this up, and this one's a battery-powered device, okay? And then you would slide a tension band off of this device and onto the penis to keep the blood in the penis, because otherwise all that blood will drain right out. But if you're using it to just stretch out the tissue for penile rehab, and let's say you do it every day, it's part of your morning routine or it's part of your nighttime routine, then you don't need to use the tension bands, and you just use this like you would for any type of rehabilitation. This, I wish all of my patients, or anybody who's treated for cancer, anybody with diabetes or high blood pressure who's not getting regular morning or nighttime erections, I wish everyone utilized a vacuum erection device, okay? When my patients come in and they haven't had any erections for a year, the common thing that they say to me is, I wish someone had told me sooner. Why didn't anyone tell me that if I didn't use it, I would lose it? And nobody regrets getting a vacuum pump, because they say, I've lost length, I've lost girth, I'm pissed, I've lost 2 inches. And I'm like, I believe you, and your tissue has changed. We need to do whatever we can to stretch out that tissue. This product here is by Gesiva Medical. There are a lot of different ones out there. You can look online. You can go to an adult sex shop. I had, many patients ask me for recommendations, and for a long period of time, I was like, oh, you can get whatever you want. Look online. It's overwhelming, and you don't know what to do. And do you need the $600 one, or can you get away with the $40 one? So we found a good product, and my patients like it, which is the most important thing. This product here is about $400. We can order it through New Care Pharmacy. You can order it yourself, but I would recommend getting a good product and using it regularly. It's like Erin's presentation. Sometimes you just have to say, okay, I know I need to do a topical ointment, or I know I need to do dilators. Do you have a recommendation? What do people like? And sometimes you start there with a recommendation. You get used to it. You see for yourself what you like and what works and what doesn't work. And then you might feel more comfortable and know what questions to ask, but you have to start somewhere. And that's where looking at the costs and the different recommendations, it puts you on the map. It gives you some sort of roadmap of a place to start, and then you find your own way in that process. And then we have the penile implant, and this is just replacing the hydraulics in the penis. And this is what the actual device looks like right here. And everything is concealed, and everything goes in the tissue, and it's very natural. So when a guy wants to get an erection, he would just there's a pump inside the scrotum, and he just goes like this, and you're moving fluid from the reservoir that's inside the body through the pump and into the cylinders. And what I think is interesting about the penile implant is, if you were to ask people in general, hey, have you ever heard of breast implants? I don't know of a single person that would say they had never heard of breast implants. However, if you ask most people, hey, have you ever heard of a penile implant? Most people would say, no, what is that? What? Penile implants? I've never heard of that before. And they're totally shocked. And they say, oh, that must be the newest and the greatest thing. It must be, someone must have just invented it. Folks, it's been around for like 50 years. And so, it goes to show that men in general don't talk about these things. Why does nobody know about a penile implant? And we just don't talk about it. But because we have the penile implant, that's why I can confidently say that there are very few men in whom we can't restore function, because it doesn't matter if you're stressed out. Doesn't matter If you don't have good blood flow to the penis, I'm going to replace that anyway with a new hydraulic system. So that's all I have for my presentation. We have about 10 minutes left for Q&A from the group. I do monthly webinars as well. You know, I tell my patients, I talk really quickly and I shout, I'm so passionate, what can I say? But some people have to hear this spiel 10 times before they understand what I'm saying, and another 10 times before they decide what to do about it. For the stuff that Erin and I are talking about this evening, you don't have to do anything. Like, this is not mandatory. You will not die if you don't do these things. And so we're giving our patients options. And sometimes there are too many options and it becomes overwhelming, and you see the eyes glaze over, and our patients are like, I'm just trying to get through my cancer recovery, and they're talking about all of these things. So the important thing is that you know there are options. And then we do it based on your timeline with the basic understanding that the longer you go without doing something, you just have to expect that your tissue will change. So if you want to optimize your results, if you want to optimize the results of your patients, then we do encourage early intervention.
Great. Thank you, Dr. Pearlman. Thank you, Erin. And we are back. So number one is, I love the normalization of the conversation. I mean, from the very beginning. And if we can't, as healthcare professionals, find a way in engaging patients, is just as you said, Dr. Pearlman, most doctors wait for the patient to say something, and patients are waiting for the doctor to say something, and nobody says it first, and so it ends up a conversation not being had. So I love the way that you gave us some advice for how a physician or providers can begin the conversation. Maybe let's flip it around. And Erin, do you have a recommendation for how a patient begins a conversation with a provider that clearly is uncomfortable?
Sure. You know, and of course, the patient, it depends on how the patient feels, how comfortable they feel bringing up this topic too. However, with women, we don't see as much conversation about sexual preservation. So when we talk about treatment for cancer, we don't often think, well, what could we do to preserve your sexual health in the type of treatment you're going to have? We just don't think about it the way we might with men. We might say, oh, maybe we should watch and wait. There is a little bit of a difference. And so for women, we're trying to get that to be a little more like men, so that our sexual health is actually considered for treatment too. So from the very beginning, we talk to patients about bringing up, how will this impact, if you're uncomfortable saying the word sex, you can say, how will this impact my marriage? How will this impact my relationship with my partner? You can even be so explicit to say, what do you mean by that? How will this affect me having vaginal penetration? Really being direct is probably what I recommend the most, so that there isn't any of this wondering what you mean, and now I'm still uncomfortable and feeling like maybe it's awkward for you to say for me to say this word to you. So I encourage patients to just ask the questions about, how is this going to impact me afterwards?
Okay,
and
great.
then I'll just add to that a little bit. So ways that I've heard patients bring it up when maybe they're seeing me for urinary symptoms and they don't know that I treat sexual dysfunction. I had a guy say to me today at the end of the conversation, would you be someone that gives me a prescription for Viagra? And like, that's literally my specialty. Like, I throw Viagra out like candy, and I'm just like, yeah, of course I can do it. You know, but he was asking, hey, is that something that you do? Or I've had patients, and this is where we're trying to teach our medical assistants. So our medical assistants will come in the room and they'll go through the medication list with patients. And they'll say, are you on Flomax? Yes. When was the last time you took it? Are you on Viagra? And our patients might say, yeah, but that doesn't work. That is an opportunity. That patient just opened the door, and that is an opportunity. So maybe the medical assistant says, oh, well, I know a bunch of providers that would be happy to see you. On your way out, you don't even need a referral. Why don't you ask to make an appointment with Dr. Pearlman? Or it's also knowing the exit strategy. So most of our providers that see these patients won't treat sexual dysfunction. That's fine, but they should make the referral. So exit strategies would be, hey, Dr. Pearlman does seminars on a regular basis. Here's a business card. Why don't you check out some information? I'll go bring the doctor in to talk about your cancer treatment. That's done. The person doesn't have to treat it. They don't have to ask any additional questions. The exit strategy is giving a business card to say, I heard you. Your concerns are important, and there's someone who wants to talk to you more about it. But that referral piece is critical.
Yeah, that's a good point. Another thing you mentioned is the medical assistant was going through that you can systematize it through questionnaires that, you know, the all of your staff systematically go through, because I'm sure, Dr. Pearlman, you have some folks in your clinic that are more comfortable. I mean, I'm talking about providers and assistants that are more comfortable and some that are less comfortable. But the more you have a checklist, if you will, or a series of questions that get asked with every patient, it becomes easier for all of the medical staff to understand this is a essential, customary part of what we do.
And could I just add one thing to that? And it really just goes nicely into that 30-second message. So that 30-second message, the reason we call it that is so everybody can understand you don't have to be on this topic for more than 30 seconds. And all you're doing is letting the patient know, you're not asking them any questions. You're just letting the patient know that sexual health issues are common and expected, and we think they're quality of life issues, and it's important that you bring those concerns to us. If you have them, we have resources to help, and even if you don't care right now, you may care later, and we want you to know we can help.
Yes.
And from the patient perspective, the patients, it's really hard to be your own advocate. And so I love after I finish talking with a patient at the end of the conversation, I might say, what questions do you have for me? I don't say, do you have questions? I say, what questions do you have for me? And patients that say, I don't have any questions, I worry about those patients. And when I turn to the partner, whoever's with the patients, and I say, what questions do you have? And they say, I don't have any questions. Neither of those people understood a word I was saying. So we encouraging patients to ask questions. Well, and when patients come in and they're like, oh, I searched on Google, what do? We as healthcare providers are like, oh, Dr. Google. No, we should encourage people to Google and look online, because that's the only way they can come up with questions and know what terms to use. So as a patient, doing your own research and advocating for yourself. And if you feel like you can't advocate for yourself, finding someone who can.
Yes. And I'd also say, you know, so many cancer doctors are probably reluctant to go into all of the questions and discern all of the problems because they don't have the knowledge or expertise to know how to deal with the problems. So obviously, if you're going to be taking care of cancer patients, I don't need to know how to do a penile implant. I don't need to know how to do everything, but I need to know who exists that I can have a relationship with to refer, so that I don't feel uncomfortable about finding out about problems and then saying, well, gosh, yeah, that's a big problem. I don't know how to. That's a bummer. I feel sorry for you. And I don't know how to fix it. But to be able to have resources in both the gynecologic world and the urology world so that we can help patients. And so I so admire what you all are doing, educating not just patients, but educating, you know, providers to be comfortable taking the history and to know that there are resources to help their patients.
Yeah, and it goes both ways. Like, I'm not going to talk to a patient about the nuances of radiation therapy, or even though I trained and I know how to remove a prostate, if someone's coming in and they're asking nuanced questions about that, I won't be the one to answer those questions. you know, but I will direct them to the person who will. And that's okay. Our patients are actually okay with us not being everything for everybody. We just have to know who those different people are and what Erin describes as building your referral network.
Mm-hmm. Yes. Chris, do we have any questions in the chat box?
Well, no, after Amy said she worries about people without
Right.
questions, I hate to say that we don't have any questions.
Well, they didn't understand a thing we said then.
I think in this case, I think a lot of great information was shared. So I wouldn't say that
And
that's
just
the case
remember
this time.
that, Chris, remember the website. It may not be up there yet, that patient handout for females. That will be up on the website. So, and I can
that's good.
also get it to you.
So we're at the end of our hour, and I might just invite each of you. So Erin, I know that you have a workshop. How would people attend that? And Dr. Pearlman, how would people attend your seminars that you do on a recurring basis? How would they find out about that? So Dr. Pearlman first, how would someone find out about your, so there we go.
UIHC.org/ED, first Tuesday of every month. And they're free, and you can just register on that website.
Excellent. And is that done via a Zoom or some internet option? Excellent. Thank you. And Erin, your
The conference coming up in April, that will also be on the project site. It will be emailed to you too, Dr. Deming. It'll be posted a lot of places, but it'll definitely be on the site. So allofmeiowa.org, if you just check that site, there will be a registration link for you to click on and go right to it. It's free. We'd love to have you join.
Great. Allofmeiowa.com.
.org.
.org. Sorry. Thank you for correcting me. Allofmeiowa.org.
That's
there
right.
we go. There we go.
Know,
well, I really.
Can I add one thing? There is a person, that just said thank you.
Thank you, Hayden.
Oh.
Thank you so much. And for the audience, this will be posted on our YouTube channel, Above and Beyond Cancer, our website, and you can spread the information and people can watch it again. And thank all of you. I want to thank all of you for attending this evening, and I'm going to turn it over to Chris for the final goodbye.
Yeah, this is, we mentioned the Iowa Cancer Consortium earlier, Erin did, and we also receive funding for these sessions through the Iowa Cancer Consortium, which is a great resource. And thanks everyone. And as Dr. Deming said, it will be on our YouTube page, and feel free to watch and advise others to do the same.
Thanks for having us.
Yeah.
Thank you. Good night.
Good night.